Welcome everyone to the IHE Standards Acceleration Lab. I'm hoping that you are now seeing my screen. My name is Keith Boone. I'm an informatics adept for Audacious Inquiry, and I'm here to basically take you through a brief explanation of what the SANER project is. And then we have a number of folks with us who are going to show you a demonstration of a lot of the different pieces of it. So thank you for joining us. So real quickly, what the SANER project is, I'll start with the acronym. It stands for Situational Awareness for Novel Epidemic Response. And this is a project we started originally at AI after talking to a number of our customers and understanding the challenges that they were faced with needing to handle manual reporting for bed and ventilator availability. Basically, some of them having to set aside even one or even more full-time equivalents just to keep up with all of that data in the hospital system. And our understanding that with FHIR APIs and automation capabilities, we could do a lot better because the manual processes, as you can see, reported even in some of the reporting components that were being done around this time last year, can take up to or approximately a half hour per response. And you might have to do this several times for all of the different reports that a single facility has to generate. Now, we use the term situational awareness in the context of this guide, but I thought I'd briefly talk a little bit about what situational awareness is. And so this is the communication of important information, what folks in the emergency response field call essential elements of information that are needed to help manage an emergency response. So a situation like a pandemic, might be an accident involving a large number of people, some other sort of natural disaster. And so the idea is that you have a way of communicating those important elements or those essential elements of information. In the emergency response field, ideally, you know in advance what these essential elements of information are. And it's not just for healthcare. This applies to everything that you might need to manage in the course of emergency response. So transportation, infrastructure, communications, affected populations, shelter, command and control, healthcare, food delivery. For example, one of the things that folks spent a lot of time on in early stages was making sure that we had a way to ensure that people who were involved in the distribution of important supplies, just to keep people going, were safe. And in the healthcare context, what we find is a lot of what happens is that these are underspecified in a healthcare context, generally getting to what's the operational status and location of hospitals, thinking about the more general case of natural disasters and larger incidents involving a large number of injuries, where you need to know where you can take people, but don't get into a lot of the detail that you might need for, say, pandemic, airborne infectious disease. So the SANER implementation guide was developed to try to address this, and really focusing on primarily the needs of healthcare providers to be able to automate the tasks of reporting from those information systems which have the data to public health and emergency response agencies and various other government agencies who were involved in the emergency response effort. There's a lot of different software applications and systems, et cetera, in this space. There's a whole market sector that's focused on emergency response software for, say, emergency operations and communications, which might receive this kind of information. There is presently now emerging a market for dealing with healthcare through healthcare APIs like FHIR, and already substantially a pretty significant market for things like public health registries and various kinds of reporting. So I've just given some, market sizes for the stakeholders. Obviously, we're sort of at the intersection of all three of these, but it just gives you an idea of how large a market there might be for something like this. And when we talk about the development of this, a lot of the effort in developing initial work on this guide is being done here in the US, but it is applicable around the world. One of the things that we did with this implementation guide is we looked at the essential elements of information as measures for process controls. And the reason that we did that is because there's a lot of science around how to use process control measures, analyze them, use them to get signals out of information that's coming in so that you can see situations that might be emerging earlier. And so these go back to common measures that for many folks who are involved with software development might be familiar with. So capacity or utilization. How much CPU am I utilizing? How much RAM am I using? How much storage am I using? We count this all the time when we're deploying applications. We're doing the same thing in the hospital with beds and ventilators and ICU beds. Event counting. In software, we count errors and faults and other things that are detected. In the healthcare environment, we count specific kinds of outcomes. We might count infections. We might count deaths, and not just how many times did this event happen today, but how much cumulatively over time, so that we can look at growth rates. Queue lengths, how many are waiting for service? How many people need to get a bed? How many people are waiting to get a test result? How many people are waiting to get an immunization? That gives you some notion of how well you're responding to the need. And then service times is an even better measure often to understand what does it take between the time that you came in and had the sample drawn and how long before you got the lab test result back to the patient. That gives you some indication of the capacity of those systems to respond to the load that's being placed on them. Because as those service times are increasing, what that's telling you is that there's more load, that therefore there should be more resources applied to that particular challenge, if that's available. And then sort of a catch-all, just being able to capture a status, say a red, green, yellow kind of status for things for which you might not actually be able to compute a number, but you can come up with a categorical indicator to say you're doing all right or you're not doing so good. I've got enough PPE supplies to last me for a week. I don't have enough to last me for a week. In collecting these measures, there are a lot of different information systems inside the hospital that have the data that tells you what's going on inside the hospital. So you've clearly and obviously got data inside the EHR, but the EHR might not be the best source for that data. If you're a hospital that's using a bed management solution, as those beds are turning over, that bed management solution knows before the EHR what beds are available, because it's closer to the data, and the EHR actually asks that bed management solution for a bed in many cases. Or in your ICU, your central monitoring solution has got direct network connections to ventilators. So as soon as a ventilator starts being used, that central monitoring system's receiving telemetry and data about the patient that's being hooked up to it, so that it knows exactly what's going on. Whereas if you're dealing with a busy ICU with patients crashing, stat intubation orders, the data might not get to the EHR until the end of the shift, when somebody has a chance to sit down and enter it all into the EHR if that's needed, to make sure that that's all up to date. So one of the things that we note in that context as well is that different information systems, some of them can be accessed directly through standards-based APIs. And so in the US, under meaningful use and 21st century cures, most of the EHR systems that hospitals and other healthcare provider are using are already supporting FHIR APIs. And you can start to ask them questions about what's going on with patients. And laboratory information systems are starting to emerge, which also support the use of FHIR APIs. But we're not seeing that so much in some of these other systems. And so we have to think about how we are able to adapt data coming in from those solutions. The structure of the SANER IG allows you to create applications that will directly integrate with information systems that speak in FHIR and collect data, compute measures, and then send them off to what we call this SANER server, but it's basically the centralized hospital infrastructure that's collecting the measure reports for later sending out to public health or others. And there are ways to adapt data so that you can take information from a bed management solution or ICU central monitoring and convert that easily from, say, a CSV format to a measure report stored in the FHIR standard using the measure report resource. And then once you've got all of the data collected from the various sources, aggregate all of that and then integrate that into a singular report that can be sent off to public health and emergency response agencies. So that's all built in, understanding the need to be able to automate and also aggregate and integrate data from a variety of other sources. The benefits here are reducing the manual effort for data reporting with the automation. And that's also been shown when you have automation to improve in data quality, because basically you've got a computer doing the task over and over and over again the same way every single time. We have the ability to adapt to existing IT solutions, preserving those existing investments, and making it easy to integrate them together. And then a way to collect all of that data and support reporting from all those disparate systems in a singular report, and that reduces connectivity challenges so that you don't have to worry about figuring out, well, how do I get all of this stuff into one report? I've got to go look at this system and that system and the other system. The SANER IG addresses a lot of those needs. At a high level, how this works is that the measures themselves, the essential elements of information, are defined by public health and emergency response agencies, and they're made accessible to solutions based on the SANER implementation guide. The hospitals and other healthcare provider organizations, so this is not just limited to hospitals, this could actually be used in ambulatory clinics, it could be used by pharmacies, it could be used by labs. It could potentially even be used by places outside of healthcare to support reporting of measure data. And then collect that data, automating it, the access to it from places where that's possible, or adapting CSV-based data from non-API enabled systems and converting that to FHIR. That server can then aggregate data from relevant systems, report that off to public health or emergency response agencies, and then that data can also be aggregated and reported up to larger regional and national level agencies. For example, we have with us today representatives from CDC, the National Healthcare Safety Network, who have been receiving some of the reports that you saw in the beginning of this presentation, starting back in about March of last year. We've accomplished quite a lot. This project started, I think my official date on it was like March 20th of last year, so we haven't even been running a year. We submitted on our first day of meeting with all of the vendors who joined us a project proposal to HL7, and that went through TSC proposal, and that was approved within 2 weeks. Based on any record I've been able to find, that's the fastest project proposal in HL7 history. We're now in our 4th Connect-a-thon. We've been through 3 HL7 Connect-a-thons over the last year, and this, the IHE North American Connect-a-thon, testing this implementation guide with at least 14 different vendors. We balloted the implementation guide in October of last year, and we're looking to have this published hopefully in May. And there have been further efforts. So the ONC STAR HIE grant program awarded the Texas Health Services Authority a grant to further development and pilot testing using the SANER implementation guide in Texas. One of the project team contributors used the SANER implementation guide in some pilot testing for home health COVID-19 laboratory testing as a subcontractor to an HHS contract. And you can see some of the visualizations that have been produced through those various Connect-a-thons and demonstrations that we participated in. I will also add, we demonstrated some of this material at the NACHO demonstration in, I think it was the either late summer or early fall of last year.